Yeah, but most of so basically these guidelines I adapted from the European Society for Vascular Surgery. It's a 2020 guideline and basically discusses management of acute limb ischemia. So this talk is going to be quite basic, and it's likely to we're going to be just giving you some definitions of what acute limb ischemia is and what causes them, how these patients present, and how we diagnose them. We're going to discuss a bit of embolic versus thrombotic discrimination, how we investigate them. And of course, before we treat these patients, there is special considerations. We don't really want to intervene on anyone like the Norths. And of course, we will also discuss treatment. So the definition of acute limb ischemia is a sudden decrease in arterial perfusion of the limb, which also results in a threat of the survival of that limb. We usually set a cutoff duration to less than 2 weeks. Anything more than 2 weeks, we usually say then it's chronic limb ischemia. And of course, this is very important to assess this patient, evaluate them so that we can manage them quicker.
I see. I think that's what I was going to surely not the
Yeah, so like I said, it is important to actually assess these patients, evaluate them quickly, so that also we can decide on the management. And you'd realize that sometimes, usually, the cause is not really that important. It's identifying that the patient has an acute limb ischemia, so that we can actually work on the treatment. So. There is many causes, but of course, we also divide them into embolic causes. And these usually the physicians would be very much familiar with them, mainly the cardiac causes of acute limb ischemia. So patients with atrial fibrillation or ventricular thrombosis post myocardial infarction, then you get these akinetic walls. That's when they develop these clots and then, of course, embolize into the distal vessels. Rheumatic heart disease, of course, patent foramen ovalis. All these patients can present, of course, with acute limb ischemia. And there is non-cardiac causes as well, such as atheroembolism and aortic mural thrombi. There's also thrombotic causes such as atherosclerosis, which is the big one that we really deal with. Foreign bodies are usually in ICU. Patients get an A line, and then of course from there develop
or a central line.
A central line. Yes, a central line. Yeah, of course, absolutely. And of course, aortic dissection and trauma. We see a lot with orthopedic patients who come in with dislocated knee, and then they end up with intimal injuries into the vessel. And of course, that will eventually lead to your acute limb ischemia.
Well, a crazy one. A guy was in the town with shots in his chest. And then he did x-rays, blah, 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 and found his left leg was ischemic. So basically the bullet went into one of the pulmonary veins and through the heart and down was ischemia.
Wow. that is, yeah. I think that's being very unlucky. It's probably not even added to the causes. Yeah, but of course, there's also the uncommon causes that patients will still present with acute limb ischemia, and it's really things that we don't normally think about, like your vasculitides, the arteries are inflamed, and then these patients, of course, clinically, they will sometimes present with bilateral disease or systemic disease as such. With signs of connective tissue disease. What was interesting also is the paradoxical embolism, whereby you've got an atrial septal defect, and then you've got a venous problem or embolus of thrombosis, and then it embolizes through the heart into the arterial system. And then you eventually get, of course, acute limb ischemia, which is very, very interesting. And of course, foreign body embolization. I think, Nelis, your case would be very fitting there. They didn't count it as such. Here, they really discuss patients that are more IV drug users. Yeah, but I think that would really fit in there. Because so these patients, when they come in, the doctor usually sitting in nice nights, a doctor sitting in Union Dale, they really call you when you're on call, and usually you're not happy with this call. But sometimes it's better to just take you back to med school. So you must just remember the 6 Ps of acute limb ischemia. Usually these patients, when they come in, they will come in complaining of pain. It's usually the initial symptom. It's quite sudden and extreme. They also got paleness, especially below the level of obstruction, pulselessness, compared to the contralateral equivalent. They will have full periphery of the affected limb, and also they will have sensation impairments because of course, neural ischemia, and eventually they will have paralysis because now the muscles as well is dying because of not getting blood supply. So it is important, of course, when we're assessing these patients, to identify their risk factors. Usually patients that smoke are hypertensive, got renal insufficiency, they are diabetic, patient with atrial fibrillation, or they've had a myocardial infarction, and now they've got this akinetic wall. These patients are all likely to present, or they have risk factors. And if you see these kind of patients, and you've got these 6 Ps type of picture, usually acute limb ischemia should be something that you also think about quite closely. So the signs is basically just the repetition of those 6 Ps: the pain on the affected limb, pallor, pulselessness, cold to touch, paresthesia, and paralysis. So when it comes to acute limb ischemia, we also have a nice classification. It's called the Rutherford classifications. Rutherford classification. It is a very nice tool, I think, because one, it informs us about the severity of the acute limb ischemia and kind of navigates how we're going to manage this patient. It kind of guides the clinical management of the patient. It also determines or tells us whether the limb is viable, it is threatened, or irreversibly ischemic, which again fits into how you're going to manage the patient. And usually when we discuss, of course, with Cape Town, or the doctors on the periphery discuss with us, if someone says, I've got a Rutherford 2B, you kind of have a picture exactly what they are talking about from the other side.
Then I know the Rutherford.
Well, it's not usually something we get. It's something that we do quite get. They're quite well versed with it, I would say. Yeah. Well, I've had kind of some couple of doctors giving me the classification, but that is the classification basically. As you can see, we grade it from 1 to 3, and usually 1 and 3 are quite straightforward, and you kind of know exactly what you're going to do for the patient. So grade 1 is, of course, a viable limb. There's no sensory loss at that time. There's no motor deficits, and there's really no immediate threat to the limb at that time. There's just patient presenting with this pain, but there's no immediate threat to the limb. And of course, Rutherford class 3 is irreversible. They have no sensation to that leg, or it's quite very diminished, and there's quite profound paralysis to the leg. And it's usually when we have this classification, likely of these patients are going to end up with an amputation. The bit of a gray zone is usually, of course, between the 2A and the 2B. Because 2A is you're marginally threatened. You still have sensation, but it is just diminished, but there's no motor deficit at that time. It's a patient that is likely going to need urgent intervention. And 2B, of course, also immediately threatened limb. The sensation is also very diminished, and of course, you also have some element of motor deficit. And now this patient is really an emergency. It's someone you really need to intervene quite quicker. So the guidelines usually say that with the Rutherford 2B, usually within less than 6 hours, you want to have already intervened with this patient, whereas with 2A, you still have about 6 to 24 hours. So sometimes, you know, when you see these patients and you just wonder if this is this really now an embolic versus thrombotic event, we can always look at say clinical features such as the severity of the pain. When a patient comes in, they're quite very painful and it's quite progressive very quickly. Whereas in the thrombotic area, remember, it develops over time, and sometimes these patients, they will have less severe pain and its progression is very slow. And of course, the onset will be within minutes on an embolic course, whereas it will be generally days to months on a thrombotic course. These patients with embolic features will also have pulses on the contralateral side. But in thrombotic picture, because these patients, like usually it's atherosclerosis, these veins are calcified, you will unlikely sometimes to find pulses on the contralateral side. And there is bruit. Is it bruit or bruit? Brewy, that's the word. It will be present in thrombotic disease because there's narrowing of that lumen, whereas it will be absent on the embolic causes. And some patients with thrombotic disease will always present of this history of claudication. They usually complain that they have claudication. So, of course, the investigations on the guideline, the guideline will say it was very interesting, but also you will see in the next slide. So they said that the digital subtraction angiography was considered as a standard of investigation for acute limb ischemia. This is something that we really that was interesting for me. And they say that it's the reason they think of this is because you can delineate etiology, but also it gives you that advantage of allowing treatment in the same setting. Now, of course, you can also perform duplex ultrasound, CT angiography, and contrasted enhanced magnetic resonance angiography. But what they recommended eventually is that they said that the CTA is the recommended investigation of choice. And one, that's because of the availability and important it is quite important in treatment planning. And that's because most of these other tools, especially the MRA and the DSA are just not readily available, and usually after hours you're just not going to have them. So they are suggesting that the first line modality for anatomical imaging is CTA, and of course that will also just give you a way forward into how you're going to manage this patient. So yeah, they recommend that. So of course, we do want to get the diagnosis, but also it is important to also just do supporting tests for this patient to know exactly what is the clinical status of the patient. It's not just the limb, but you're managing the entire patient. So of course you want to know the urea and the electrolytes with the creatinine, and also it's important to know the creatinine if you're going to put this patient and get a CTA, because usually they don't want to scan patients with a GFR of less than 30 because of associated mortality apparently. And
listen, I think we don't need to get into the subject of contrast, but I think it's up to us. Because the other day we also had this question with your other lady, can we CT?
Mm.
And really, if you think it's going to change the management, then we should push, because we're looking after patients, not the radiologist or the radiographers. So I think if you feel it's indicated and it's a limb that you can save, and now you're not doing it, then you must do it.
Yeah.
I mean, there is controversy if something like contrast-induced nephropathy exists for a start. But I mean, first you would just do it. I mean, I have no qualms about doing it. I think when you're doing, no, I know they feel that it isn't really a thing. Maybe if you do repeat it like cardiac, and you give like large doses, they feel sometimes they might see it, but they feel you should go ahead and do it. And it says in an emergency. Just to reiterate, in an emergency, don't need a creatinine. and this is an emergency.
Yeah.
You know,
Sure.
you either lose a limb or not. So I think we must not let that stop us from doing important investigation.
Yeah. No, sometimes we try to decide of resources are available and trying to save.
So just to say, I mean, dialysis is available for us. So and it costs about, we discussed it today. So for a 4-hour session, it's 4,000 rand. So when you put that in perspective of, I don't know, how much does that big plate cost vessel that you want to put into that lady? Yeah. But how much is that plate?
It's at least more than 1,000 rand.
Sure.
Right, for that
For a plate.
So just all the plates are special. That's why they cost them. But it just put things in perspective.
Yeah.
So I don't think that, and we are actually not dialyzing a lot of acute dialysis. We are not spending a lot of money on it. I mean, this week was a bit abnormal. Dialysis for people, but
yeah,
I don't think that should stop us.
Yeah. Okay. So that's something to really think about, because really these patients, some of them, they actually have a good prognosis and quality of life if you can save that limb, whereas you can render them dependent once you don't save the limb.
You want to get them back to work.
So yeah,
you want to get them back to work.
We want them to go back to work. Yeah. So of course, yeah. So also, full blood counts, chest X-rays, ECGs, of course, to make sure the patient doesn't have AF, and in young patients, we also want to do a thrombophilia screen, and they want to know the HIV status of the patient.
What is a thrombophilia screen? You do the whole work.
Everything up and we should be doing them according to the guidelines. We should be doing them according to the guidelines, but I don't.
In the absence of other causes, it's the young patient thing.
RPR first name.
Okay.
Yeah, fair enough.
And I think the problem with them is that for acute thrombus, oftentimes the factor light and the
protein for antiphospholipid.
Yeah, so you actually need to do them 6 weeks down the line, not acutely. We don't do that for venous thromboembolism also. We wait for the thrombus to get out of the system and then you do the screen.
Okay.
But not an easy budget.
Yeah, okay. Yeah.
I think that's more trauma.
We do see quite a.
They don't see it often. I think reality is going to be a patient with some underlying disease.
Yeah, that's what I'm saying. If we get a young patient, then we might as well spend the money on one.
But what I'm saying, acute thrombus levels will be abnormal, even in patients that don't have it. So normally thrombophilia.
The later stage.
So 6 weeks down the line, then you get investigated, because otherwise you get false or false tests.
But we can still do the basic things like the HIV, the cheap tests. Yeah, they are cheap. Yeah. Of course, could give you a lot of information if they are positive. Of course, before we treat the patients, of course, it's also just very important to have special considerations, like such as the patient's age, the fitness and comorbidities. I mean, if a patient is like ECOG4, they frail, they very end of life, and maybe have like a metastatic disease, it's unlikely that you're going to want to get this patient to Cape Town for intervention. And also you want to understand what is their current and projected quality of life. And I make a very nice example saying that it might not be appropriate to actually save a leg of a patient in a wheelchair requiring, you need to amputate that patient. But in the same patient, if now they have an upper limb ischemia, maybe you would want to actually give a chance to that patient, because it also ensures the function and continued independence thereafter, but maybe not appropriate to actually save their leg. So it's one of those things you want to understand: what is the projected quality of life for this patient? And of course, what can be offered on the patient.
Yes, some guy now, the ECOG4, it's wheelchair bound and now got upper limb ischemia. And then you remove the clot. You need to give drugs and prevent it further. And now they are already like compromised. Even those drugs are risky.
I don't think we will stop them before they get to you, I must say. They're getting morphine and
Yeah, I think usually EC really does that quite well. I think understanding also that palliative is a form of treatment. I think it's something that is well understood and something that is.
Another gentleman with the iliac. No, who was it? I don't remember. He had, I mean, it's the angel, but he had a obstruction with the iliacs and then with a dead limb. You know.
Yeah.
Can you put him in a scan or not? Because I don't know, my good.
Morphine.
Yeah.
Yeah. And sometimes, also just something to consider is patients' wishes as well, and of course of those of their relatives. It's like you have an elderly patient with severe acute limb ischemia and they require an amputation, but then the patient is saying, you know what, rather my life ends. But it's also very important, even though you understand that it's true, you need to involve the relatives. And counsel them, do inform them about what is available, and there must be discussion, and the decisions that are made, they must be clearly recorded, because sometimes these patients, the relatives, can actually come back with a lawsuit after that. But I think it's important to respect the wishes of the patients as well. But I think it needs to be appropriate as well. Of course, how we manage these patients, we start initially with very important to, of course, classify what severity you're dealing with, and so that you can actually transfer early for definitive care. It doesn't help keeping a patient in George if you know that they're going to need like a hybrid theater of sorts. And they're going to need a quite invasive intervention, and something that maybe we do not have a skill for. And also we must document time frames, because that is also very important. So we also have to preempt reperfusion syndromes. So we need to basically hydrate these patients quite well and monitor their urine output. We also need to anticoagulate them with heparin. There's a study from UCT by Dr. Naidu, actually added on the reference. And Groteskir, basically what they do is that, so they will start with the stat dose of 80 to 100 units IV, but they say that most units uses 5,000 units in a given, that, they will give 5,000 units stat. And then what they would do is that they would give a heparin infusion with 25,000 units in 200 mils of normal saline, and then they run it at 8 mils per hour. And then after that, they will do a PTT every 6 hours, and then they titrate it according to what the value is. And then other supportive measures is, of course, you want to give these patients oxygen, adequate analgesia. It can be quite painful. And of course, you want to put the leg in a gravity-dependent position so that you can just encourage as much flow as you can. So an anti-Trendelenburg back position is also recommended. So as a rule of thumb, so the Rutherford 1 and 2A, so these patients can get a CTA for decision making, whereas a Rutherford B needs an urgent transfer to either to Groteskir, or if it's something that we can actually know that we can do an embolectomy for, then we need to try and sort that out as soon as possible, because this is a time sensitive, and usually they say less than 6 hours you need to have definitive management for this patient. And Rutherford 3 usually will get a primary amputation because the limb is non-salvageable. So the treatment options usually then, as I've discussed, is anticoagulation, which is usually your medical management, and then it's operative, and then endovascular. And of course, that depends on what is available really in your environment. And the main target, of course, for acute limb ischemia is you want to restore arterial flow with the least risk to the patient. The revascularization should be performed on urgent basis, about 6 to 24 hours, and that's for your Forest 2A. Rutherford 2A. For immediately threatened limbs, it should be performed emergently within 6 hours. And for the non-salvageable limb, of course, amputation should be performed as the first procedure. Okay. So yeah, of course, the first one is, of course, medical management, and we're anticoagulating the patient. And then for the endovascular therapies, we can always use thrombolysis or mechanical interventions. And then for surgical interventions, we can use thromboembolectomy with a Foccari balloon catheter. I think that's the only one I've actually seen being done. We've got, yeah. And then they can also, although quite rare in acute limb ischemia, they can have bypass surgery, but it's not something that is really commonly practiced. Intraoperative thrombolysis, or they get an amputation. That's as much as surgical intervention is concerned. So intraarterial thrombolysis, of course, what they would do is that they will take a catheter and pass it into the occluded vessel, and then they will leave it embedded in that clot, and then they will infuse the thrombolytic agent over 24 to 48 hours. Although if in 24 hours time there's still no dissolution of the clot, then they will just abandon this intervention. And now the thrombolytic agents that they use is TPA, altiplase, tenecteplase, and reteplase. Apparently, they no longer uses urokinase and streptokinase. Actually, didn't get why they don't use them, but the guideline says that they don't use them anymore. And for patients with profound ischemia who may not tolerate such a prolonged procedure, and then definitely not some people, they should not be considered for this intervention. So percutaneous endovascular thrombolysis options are more effective with the patients that are have a viable limb or marginally threatened. So Rutherford 1 and 2A. Patients with arterial thrombosis, or patients that have a synthetic graft and now have developed thrombosis. If the patient has stent thrombosis as well, they would benefit from an intraarterial thrombolysis. And then catheter-directed thrombolysis, or CDT. The good part about it is the fact that you can actually deliver the drug into the existing thrombus directly, and it will reduce the amount of drug that is needed. It lyses the clot in both large and small vessels. There's lower reperfusion syndrome than when you have an embolectomy, because you just have that. So you can actually you break down the clot quite slowly, whereas when you do an embolectomy, once you relieve the clot, all the toxins and the free radicals just flow back. And this can be done via percutaneous approach with local anesthesia. You can just open up with local anesthesia and insert the catheter, and then you just infuse the drug. The consequences, of course, is the fact that it takes so long, 24 hours, to be effective. And in 6 to 9 patients, there's a risk of major bleeding. Then contraindications to using thrombolytics is, of course, what we normally see quite a lot, even with patients that have strokes and now they need to be thrombolyzed. The absolute contraindication is that if a patient has an established cerebrovascular accident within the last 2 months, or they actively bleeding, if they have had a recent GI bleeding within the 10 days, if they've had a neurosurgery within neurosurgery intervention within the last 3 months, or intracranial trauma within the last 3 months, all these patients should not actually get the tenecteplase or the altiplase or the TPA. And then the relative risks, relative contraindications would be a patient that has had CPR within the last 10 days. Not sure why CPR would actually feature, but also it is a relative contraindication. And patients with uncontrolled hypertension, puncture of an uncompressible vessel, and recent eye surgery, also pregnancy. Then, of course, we move to mechanical thrombectomy. And usually it's percutaneous mechanical thrombectomy with mechanical pulse spray or suction with a catheter. I think it's called an angiojet. I've actually not seen how they actually do that. I tried to watch a video and I still struggle to actually see how the angiojet actually works. But it's also the same concept that you're going to actually go into the vessel with the catheter, and then it will disrupt the thrombus and allow better penetration of the clot. And of course, it's going to require less amount of the drug, and you can always do it under local as well, with just an anesthetic person available. And then this one is a surgical thromboembolectomy. It's what we kind of used to. You can also do it under local or general anesthesia. So the artery, usually the larger proximal part, will be exposed, and then we will just put the slings around the artery, and then we can either make an incision transverse or longitudinal. Most surgeons will say that the transverse is much better because it prevents the narrowing of the lumen. And then if you do, of course, a longitudinal, sometimes you need to actually use a patch, yes, to actually close that vessel to prevent the narrowing of the lumen. And then we normally use the Fogarty balloon catheter, and we just insert it all the way distal to the clot. And then what happens is that you're going to blow it, and then you just pull it back with that clot. And of course, what is a good result is the fact that you can see good backflow or anterograde bleeding as well. That will tell you that the clot has been removed. And then, of course, these patients after the procedure should benefit from an angiography as well to ascertain how adequate the procedure was. And of course, surgical thromboembolectomy as well has its pros. It's the fact that you will have rapid revascularization, and of course, you understand that the reperfusion injury is then going to be a challenge for this patient. But the good thing is the fact that you also can do it via local anesthesia. I've never seen this being done under local anesthesia though, but the guidelines say that you can actually do it under local anesthesia. And of course, the consequences is the risk of vessel injury and reperfusion injury. And of course, when you have a reperfusion injury, that eventually the limb may end up quite swollen, and you eventually get compartment syndrome as well. Arterial bypass surgery is also something that they do offer. And most of these interventions are done in Cape Town. And they use in the patient. So the arterial bypass basically will be for patients that have failed other procedures. They use this as a last resort. Because of course, patients with severe tissue injury and associated peripheral vascular disease.
So our patients that we get this, because it's that typical peripheral vascular patient admit with a blue toe, discuss with vascular, transvascular. Thanks. Acute. I think that's
acute and chronic. Yeah, usually we do.
It's raised to a lot of ways. There was correct me if I'm wrong, there was a period where the rate training and surgery changed, but they weren't trained in the specific vascular stuff. So don't get any still qualified to do it. I mean, they can do it, but on paper they shouldn't want to.
No, it's a high risk. It's quite high risk, and the complication rates are quite high. And I think it's about the training. Like they've got basic training, but I think if you want to call yourself a vascular surgeon, you need to.
That's quite fair.
Vascular surgeons struggle.
Yeah, that's.
That's like do another PTAs.
You do see a lot of these patients also coming back there with all these complications. It's something that we see quite common, I must admit. Yeah, but of course, bypass usually can be also the mainstay treatment for thrombosed popliteal artery aneurysm, high surgical risk patients, but it's rarely used for acute limb ischemia. And of course, with patients that are Rutherford class 3, or they've just got a low potential of actually saving that limb. And if a patient has got a significantly higher up level of obstruction, then the risk of perfusion is too high. We may end up just amputating the limb because the reperfusion syndrome is likely to just kill the patient as well. Yeah, so the complications of arterial revascularization, of course, like we said, it's the reperfusion syndrome. And most of these patients will have hypertension, they'll have hyperkalemia, myoglobinuria, which will then crystallize in the glomeruli and eventually subsequently lead to renal failure. We will also see patients having compartment syndrome because they just become edematous, and they get compartment syndrome. They will get ischemic neuropathies, sometimes muscle necrosis, and sometimes it can just the thrombosis just recurs, and they'll have that lower leg swelling. So patients also with, of course, compartment syndrome. Every reperfused patient is monitored for this complication. It's quite important, and it can occur after prolonged ischemia that is followed then by reperfusion. We put in that focati, then we pull that clot out, and then there's reperfusion, and then it's that the fluid, the interstitial fluid, will start filling in the compartment spaces, and then usually these patients will then have excessive pain, usually pain on passive stretch, and you'll see that the pain is just out of keeping with what with your clinical assessment, and then they'll complain of sensory loss as well due to the nerve compression. They say that the pressures can actually be measured by inserting an arterial line into the compartment. And then
just take advantage. You take the needle and just pop it into that. Just make sure in the right compartment.
Yeah.
Because if you think about it, it makes sense.
It does, yeah. So they say again, the pressures that are more than 20 millimeters of mercury are an indication for then a fasciotomy. So that is what the guidelines are saying.
It's another measurement that they used to have is within 20 millimeters of your diastolic blood pressure or something like that.
Yeah.
Also, if you think about it, you should do it. If you think that you should do it, I should.
Yes. It's usually clinical diagnosis.
I think for the more, so if they do, if you had a prolonged time of ischemia and you have to do more than a colectomy, they usually tissue damage is already there, and then also reperfusion will then add insult to injury.
In some cases, we can start with a fasciotomy to see how the vessels and compartments
Yeah, I mean, that's quite important. There's no point in you restore the limb, but then half the tissue dead. And also just to remember rhabdomolysis, with the dead limb and dead muscle. And it's interesting, you only need, like this lady in the ICU, she had a gluteus torsion, but you only need 100 grams of muscle to push your CK by the 1,000. So, and remember your diagnosis of rhabdomolysis is more than 1,000. But look, no one gets excited with 1,000. But it just goes to show how little muscle damage you actually need to push up your CK. So I think just keep an eye on that.
Yeah.